Bismillah ar-Rahman ar-Rahim. Assalamu alaikum wa rahmatullahi wa barakatuh. In this short session, inshallah, we are going to discuss acute shortness of breath for MRCP, and with a special focus on acute severe asthma and acute exacerbation of COPD. Of course, acute dyspnea is one of the high-yield topics in MRCP exams, and also it's a very important topic in real-life practice. So almost in the emergency department, you will encounter a patient with acute shortness of breath, and you need to use your clinical sense, taking focused history and focused clinical examination, doing basic investigations to reach the diagnosis. Of course, many causes of acute shortness of breath, and as you know, in the era of COVID-19, any patient with acute dyspnea coming now to the emergency department, you should think in COVID-19 pneumonia. And so I think this is going to be a high yield topic in the next bite in September. So I think everyone is going to attend the next exam needs to read in this topic, COVID-19 pneumonia and the acute management of patients with pneumonia. This session, inshallah, we are going to focus, as I said, on the acute exacerbation of COPD and acute severe asthma. Also, we will have like a hint on a pneumothorax. A patient coming with acute dyspnea, of course, you will, as I said, you will take a focused history and a clinical examination, and you will do your basic investigations. The basic things should be in your mind. So the life-threatening causes of acute dyspnea, you have to think in these causes first before thinking in the other simple causes. Of course, on the top of this list is acute pulmonary embolism, acute exacerbation of COPD, and acute severe asthma. Of course, acute heart failure and pulmonary edema, or non-cardiogenic pulmonary edema, due to severe pneumonia, due to severe sepsis, severe trauma after acute pancreatitis, and so on. Also, patients with acute coronary syndrome, patients with cardiac tamponade, patients with pneumothorax, significant pneumothorax, and patients also with massive pleural effusions, patients with pneumonia. Okay, so these are the basic causes of acute shortness of breath in the emergency department. We will have a special focus on patients with acute severe asthma and acute COPD exacerbation. Sometimes actually the differentiation between these two causes is not easy and is not straightforward, but taking, as I said, a focused history and doing clinical examinations sometimes and mostly it's very helpful to differentiate between these two causes. Of course, the presence of history of smoking or long-term smoking for many years, of course, support the diagnosis of acute exacerbation of COPD. Absence of the history of smoking will favor the presence of asthma or bronchial asthma. But sometimes you will have a patient with COPD, emphysematous patient, in the absence of history of smoking, of course, and in a young patient. And in these patients, of course, if you have been encountered with these patients in the practice, or you have been asked about this in one of the exam questions, you should think in alpha-1 antitrypsin deficiency. So alpha-1 antitrypsin deficiency, it will be a patient with acute asthma, or acute shortness of breath in the emergency department, and no history of smoking, and will have the picture of a hyperinflated chest, so emphysematous patient, and you will have also some data about, probably you may have some data about the TLCO, and you will have some data about the respirometer of the patients. So probably the respirometer of the patient will show an obstructive pattern, and the TLCO will be reduced in this patient. But generally speaking, a patient without history of smoking and young patients with a history of repeated attacks, especially nocturnal attacks, mostly this is an acute asthmatic patient and not acute exacerbation of COPD. Also, the presence of eosinophilia on CBC supports the diagnosis of acute asthma. The presence of elevated IgE levels also support the diagnosis of acute asthma. If we find an hyperinflated X-ray, hyperinflated lungs on the chest X-ray, this will support the diagnosis, mostly will support the diagnosis of acute COPD exacerbation. Okay, so you will need to differentiate between these two conditions, but mostly in the exam question, the diagnosis will be clear. So patient with long-term history of cough, expectorations, and smoking, and recurrent attacks of cough, expectorations, and this is a clear history for a COPD, and is coming with acute exacerbation. And as you know, usually these patients with COPD has a normal day-to-day variations. An exacerbation means that this variation become beyond the accepted or beyond the usual variations. So this is an acute deterioration of the patient beyond the normal day-to-day variation. Usually will be associated with excess cough, expectoration, usually a colored sputum. Of course, after you differentiate between those, and as I said, sometimes in the question or in the exam and in real life practice, the differentiation is a bit straightforward between patients with asthma. Usually the patient will have a clear history of bronchial asthma, and the other patient will have a clear history, very suggestive of COPD. After that, you need to assess the severity, because this will affect also your choices of medications or admissions, and giving some specific medications according to the severity. So, for example, if you have a patient coming to the emergency department with history of acute asthma, and you have been given in the question that the patient cannot complete sentences in one breath. If you find this sentence in the exam question and in real life practice, of course, this means that this patient has acute severe asthma. Okay, so if the patient cannot complete sentences in one breath during breath, so this is a severe attack. If the patient can speak, in the question, if the patient can speak normally and can complete one or two sentences during breathing, this patient does not have severe attack. It may be mild to moderate attack. Okay. For a life-threatening asthma, the patient will have these features. Of course, cannot complete one sentences, but the patient start to be exhausted, say nosed, hypotensive, and there is loss of respiratory effort. And at the same time, this patient will show some basic parameters, which means that this patient now has a life-threatening asthma. These include some basic parameters. On the oximeter, you will find the oxygen saturation below 92. So any oxygen saturation below 92 in a patient with acute severe asthma means that this patient has a life-threatening asthma. And if you check your ABG, and ABG is one of the essential investigations in patients with acute severe asthma or life-threatening asthma, you will find that the PO2 will be below 8 kPa, or it's below 60 millimeter mercury. Okay, and your CO2 will be in the normal range. Usually, CO2 should be washed during the acute severe asthma. If the CO2 is within normal range, so you have to pick this. This means that this is a life-threatening asthma. Okay, so PO2 is below 92, below 60, or below 8 kPa, or the oxygen saturation is below 92, or the CO2 is the PCO2 is within the normal range. So it's from 4 to 6, something like this. Okay, in this range. If CO2 is in this range, from 4 to 6 kPa, so that means that this patient has a life-threatening asthma. A patient with a near fatal asthma means that this patient had all of these previous features in addition to a high CO2. Okay, so if you have been given in the question or in the exam question, and of course we don't need to repeat this in real life practice. Of course, if you have been given this, that the CO2 starts to be high, so it's above 6 now, or it's above 50 millimeter mercury, the PCO2, that means that this patient has a near fatal asthma. In acute severe asthma, CO2 should be washed. In a life-threatening asthma, the CO2 or the PCO2 is within the normal range. And in near fatal asthma, the PCO2 is high than normal. Okay, oxygen saturation, once it's below 92, that means it equals life-threatening acute bronchial asthma. It just the patient has tachypnea, tachycardia, and cannot complete one sentences, and still the oxygen saturation is above 92, or the PO2 is still above 8, and CO2 is lower, so it's still washed, it's below 4 kPa. That means that this patient has acute severe asthma, but it's not life-threatening. Once you find the patient cynosed, exhausted, there is loss of respiratory effort, there is hypotension, this means that the patient had a life-threatening attack. And management of life-threatening attack will differ, of course, from the management of acute severe attack or near fatal attack, mild to moderate attack. Okay, so if the patient does not show any signs of acute severe asthma, so the patient can speak normally, can complete 1 or 2 sentences, no significant tachypnea, no significant tachycardia, just mild tachypnea, and still the oxygen saturation is okay, and PO2 is okay, and CO2 is washed, mildly washed. That means the patient has a mild to moderate attack. Okay, so you have to, when you are dealing with this patient with acute severe asthma, you have to check rapidly what you have been asked about. So if you have been given any information about CO2, about PO2, about oxygen saturations, about the clinical presentation, so can speak one sentence, can't speak, or exhausted, cyanosis, hypertension, you have to check this. But again, just to recap this point, PCO2 high means it's a near fatal acute bronchial asthma. If PCO2 is within normal range, probably you are dealing with a patient with life-threatening asthma. If CO2 is still washed, but the patient cannot complete one sentence, that means you are dealing with acute severe asthma. Okay, hope that this is clear, because usually you will be given some of these data in the exam. Okay. Let's go to just before we go to the management. If the patient is clear that he has an acute exacerbation of COPD, so an important part of your evaluation is to assess the need for admission in the hospital and probably the need for some ICU setting. Of course, acute severe, the patients with acute severe exacerbation of COPD will show a low oxygen saturation. So if the oxygen saturation is below 90, that means we are dealing with a patient with acute severe exacerbation of COPD. Okay, and if the patient shows that the PO2 of the patient is below 7, that means we are dealing with a patient with acute severe exacerbation of COPD. If the oxygen saturation is above 90 and the PO2 is still above 7, and there are no signs of severe respiratory distress, so no cyanosis, no severe tachypnea, no severe respiratory distress, and no acidosis on the APG, and no significantly high PCO2 and low oxygen saturation, so that means that the patient maybe have a mild to moderate attack. So if the patient is not severely distressed, oxygen saturation is above 90, and sometimes also you may be given a hint or a data about the forced expiratory volume 1, FEV1 in these patients will be below 30 in severe attacks. Okay. Yeah, so a severe attack, usually that means that the patient will need admission. If you have a significant, so sometimes you may be given a data about the patient coming to emergency department with acute shortness of breath and has a long history of COPD and is now coming with acute exacerbation, and you will be given a data about the APG of the patient, and you will find that the pH of the patient is 7.2. So that's significant, kind of significant acidosis. And in these patients, your choice in the management, of course, you will start all your initial management steps, including nebulizers or oxygen, controlled use of oxygen or nebulizers, or maybe aminophylline, steroids, and so on. You may be asked about if the patient already has been given these medications, about the next step, and still the APG showing such significant acidosis. Of course, your choice will be between non-invasive ventilations, BiPAP ventilation, or mechanical ventilation. Classically speaking, if the pH is below 7.25, means that the patient will need probably mechanical ventilation. But the choice between mechanical ventilation and non-invasive ventilation, of course, many factors are involved. we will speak about the details in these points. Okay, so let's go to the next point about management regarding acute severe asthma or acute exacerbation of COPD, because the management seems a bit similar in these two conditions, but there are some major differences we have to consider. Of course, we will start with the basic management. We will start with oxygen. Okay. Of course, in a patient with acute exacerbation of COPD, you will need to give oxygen. In patients with acute severe asthma, you'll need to give oxygen. So what's the difference? In a patient with acute severe asthma, probably you will need to give a high flow oxygen. Okay, so you give high flow oxygen safely, and no limitations in giving your oxygen. You want to keep the oxygen saturation in patients with acute severe asthma between 94 and 98. Okay, so what is the best way to give this high flow oxygen? Of course, you can give by nasal plunge, maybe by face mask, but the best way to give a high flow oxygen, of course, is to give through a non-repriser mask. Okay, so what about the patient with acute COPD exacerbation? In these patients, still you can give high flow oxygen. Okay, the rule in these patients is to keep the oxygen saturation of the patient between 88 and 92. Okay, so your best way to give such controlled oxygen therapy will be through a Venturi mask. So in Venturi mask, you can control the fraction of inspired oxygen to the patient. You can control the saturation of oxygen you are giving, maybe 24, maybe 28, maybe 40, maybe 60. And you will need to control this according to your ABG. This only if the patient is retaining CO2. So if there is CO2 retention and the patient shows high levels of CO2, that means you need to give controlled flow of oxygen. And the best way is to give this through Venturi mask. Okay, don't give a non-repriser mask. Non-repriser mask means you are giving now a high flow oxygen, even more than 60%. It's now up to 80%. Okay. Sometimes you may need, even you may give 100% oxygen. So in COPD patients, the classic rule is to keep or maintain the oxygen saturation between 88 and 92. But if the patient does not retain CO2 and the CO2 of the patient is within the normal range, that means you can still give high flow oxygen through a non-repriser mask or through Venturi mask, whatever. If there is CO2 retention, it's best to give the patient oxygen through Venturi mask. One of the repeated and the classic questions in these scenarios, you have a patient coming with acute exacerbation of COPD, and you started your medications with nebulizers and beta stimulants and muscarinic antagonist, short acting, and oxygen also is given at saturation of 28 or 40% of oxygen saturation already has been given, and ABG is done after this initial treatment, and you will find that the oxygen saturation starts to improve. However, the CO2 increasing. So if you are giving a high flow oxygen in these patients, and the CO2 was a bit high, and now it's increasing, and so the patient is taking a bit high flow of oxygen. So there is depression of the respiratory drive in this patient. So what will be the next step? This patient? The next step for this patient, of course, if the oxygen is going up and higher, and the CO2 is going higher also, so probably you will need to lower your oxygen saturation. So the best next step, if the patient is taking 40%, you will be asked about a lower level of oxygen. So you may have the choice of giving 28 or 24% of oxygen. Sometimes maybe the next step is to go to the next option, which is a non-invasive ventilation of the patient. So you may find that the PO2 is not rising, but the CO2 is rising. So if CO2 is rising and the PO2 is not rising, what does this mean? This means that you cannot give a lower flow of oxygen. So if you give a lower flow of oxygen, this means that the oxygen will go even lower again. Still your oxygen is not rising, it's even lower or even the same. So no improvement of oxygenation, but the CO2 is going up, and your pH now is in the acidotic range between 7.25 and 7.35. The next step, or the best next step for these cases, will be, according to the MRCP common questions and according to the clinical scenarios and real life practice, will be non-invasive ventilation. So sometimes you may go down with your oxygen saturation if the oxygen is rising, and now it's better and it's high. Now it's 90, 95, 94, but the CO2 is going higher, and the patient starts to be acidotic. In this case, you need to go down with your oxygen saturation you are giving to the patients. If it's 40, you go to 28. If it's 28, you may go to 24, and so on. But if the CO2 is rising and oxygen is not rising, the next step that you want to try to improve oxygenation and improve also washing of CO2 by non-invasive ventilation. I hope that this point is a bit clear. Okay, so regarding oxygen, high flow oxygen in patients with acute severe bronchial asthma is the rule. And COPD, you will give controlled flow through venturi mask or high flow, and your aim is to keep the saturation between 94 and 98. Okay, I hope that this point of oxygen is a bit clear for my colleagues. Okay. What about nebulizers? So in patients with acute severe asthma, your initial steps, either acute severe asthma or a life-threatening asthma, your initial step of management after oxygen, of course, you as I said, you give oxygen by nasal plunges or by mask. It doesn't usually, if you need to give a nebulizer, so probably you will ask yourself. So regarding nebulizers, the drive for these nebulizers, for salbutamol or for ipratropium bromide, should be air, compressed air, or should be oxygen. In COPD patients, it's better to give through compressed air, especially if the patient is CO2 retainer. But still, you can give oxygen through nasal cannula, and you give a nebulizer through compressed air. Okay. In patients with acute severe asthma, it's better to give oxygen, to give a nebulizer through via oxygen. Okay. So your drive for the nebulizer will be oxygen in this case. You may give by a Venturi mask, you may give even the patients even, as I said, a high flow of oxygen. Okay. So a nebulizer may be driven by a compressed air, that's the best choice in COPD, with CO2 retention. Still, in addition to nasal cannula giving low flow oxygen if the oxygen is low. Our target in COPD is 88 to 92 in those patients who retain CO2. In asthma, our target is 94 to 98. Okay. We start usually with a short-acting beta stimulant, salbutamol inhaler. Sometimes in children, especially in children young, 1 year and more, we may start with inhalers. So we ask the carer, the mother, the father, whatever, the carer to give the patient, to give the child repeated and frequent inhalers using beta-2 stimulants. Usually this is given maybe every 30 seconds or 60 seconds for 10 doses. And if there is no improvement, they must bring the child to the emergency department. Okay, so inhalers can be used in the pediatric patients, but in adult patients this is not used. Of course, the patient can use at home, but once the patient in the hospital, you must give nebulizers, salbutamol or ipratropium bromide. Initial nebulizer, whatever, in COPD patients, and in asthmatic patients should be a short-acting beta-2 stimulants. Okay. Sometimes IV nebulizers, IV beta-2 stimulants can be given if the patient does not respond to the initial nebulizers using beta-2 stimulants. So still, IV salbutamol can be given in these patients. Okay, so this is an important point also. But the rule is starting with short-acting beta-2 stimulants, give a short-acting muscarinic antagonist, ipratropium bromide. Usually it's given at a dose of 500 micrograms, and high dose salbutamol, as I said. So you give both in patients with acute severe asthma or a severe acute exacerbation of COPD. But remember, the drive for this, it's best to be oxygen in asthmatic patients. The drive for the nebulizer in patients with COPD, best to be compressed air, or through a low flow oxygen through a Venturi mask. Okay, so don't forget that high flow oxygen, so a non-repriser mask, the rule in patients with acute severe asthma or a life-threatening asthma. But for a patient with COPD, it's a Venturi mask, especially if there is CO2 retention. Okay. Next point is aminophylline. Can we use aminophylline in patients with acute severe asthma? Actually, no. So in acute severe asthma, there is no rule for aminophylline. It's not very significant. In patients with COPD, yes, you can give IV aminophylline. So in the scenario, in the stent, if the patient has been given nebulizers and steroids and there is no good response, you may be given the option of giving aminophylline, IV aminophylline. Of course, you must note if the patient is already taking oral aminophylline, because in these patients, toxicity will be more easier. So take care in patients who are taking oral aminophylline, or you may be given in the scenario that the patient is taking some drugs that may increase the toxicity of aminophylline. This is especially important in patients with COPD exacerbation. So you have to know that the patient is taking, for example, ciprofloxacin, which is an enzyme inhibitor. If the patient is taking ciprofloxacin, an enzyme inhibitor, so you need to reduce the dose of aminophylline. And the patient showed signs of aminophylline toxicity in the question, and you will be asked what's the most likely cause for this. So you must check you must check the medications, the list of medications the patient is already taking, and check, of course, for the enzyme inhibitors like omeprazole, like ciprofloxacin, or any other enzyme inhibitor. Just check in your medication list in the question, and in real life, of course. So aminophylline is given in COPD exacerbation. It's not given in acute severe asthma. It may be given in pediatric asthmatic patients. So still aminophylline can be given in the pediatric age. Okay. Is there any rule for nebulized magnesium sulfate in COPD patients? No rule for magnesium sulfate. So no rule at all in exacerbations, either IV or nebulized magnesium sulfate. Okay, so no rule at all in these patients. There is a rule for nebulized magnesium sulfate only in pediatric acute severe asthma. So in acute severe asthma in a child 1 year or more, there is a rule for nebulized 150 microgram of magnesium sulfate, in addition to beta-2 stimulants and short-acting muscarinic antagonists. Okay, so there is no rule for nebulized magnesium sulfate as a general rule in asthmatic patients or COPD patients, only in pediatric asthmatic patients. Okay. About IV magnesium sulfate, of course, no rule for IV magnesium sulfate in COPD. Okay, so you will give oxygen, controlled flow oxygen, and nebulizers. As I said, probably you may, and steroids. In both cases, COPD patients and in asthmatic patients, steroids are very, very important, and we will go through this. In magnesium sulfate, there is a rule for magnesium sulfate in acute severe asthma that's not responsive to the other measures. So you will be asked in the question, a patient coming with acute severe asthma, so can't speak for 1 sentences, and he already now is given inhaled nebulizers, salbutamol, ipratropium, oxygen, and steroids, oral or IV steroid, and no good response, and still the oxygen saturation is below 92, or the patient still start to be exhausted, or CO2 is still within the normal range. It's a life-threatening situation. So the best next step for this patient is to give IV magnesium sulfate, 2 grams of IV magnesium sulfate, slow IV, over 20 minutes. Okay, 2 grams slow IV over 20 minutes. In a patient with life-threatening asthma, after starting your initial treatment, or a patient with acute severe asthma and still not responding properly. No rule for magnesium sulfate in COPD patients. Okay, in pediatric asthmatic patients, still you can give nebulized magnesium sulfate, IV magnesium sulfate in a patient not responding to the other measures by dose 25 microgram per kg. Okay, 25 milligram per kg. Okay, what about steroids? The rule in patients with acute asthma and COPD is to give oral steroids. If the patients cannot take oral steroids, instead you can give IV steroids. Okay. Usually we use prednisolone. Okay, oral prednisolone as a usual treatment in these patients. In acute severe asthma, you start with on prednisolone 40 milligram. Usually maximum for 5 days. So maximum dose is usually we give 40 milligram for 5 days. Usually maybe given even less than these 5 days, but maximum for 5 days in the acute severe attacks. Okay, so oral is enough. Instead you can give IV, but this is not the rule. Okay, what about patients with COPD? Patients with COPD also usually is given prednisolone for a short period of time, usually not more than 1 week. It may be maybe a bit longer, but this is the usual course. And during the exacerbation, just 1 week of prednisolone, 30 milligrams, is given during the acute exacerbation in severe patients. Okay, so usually steroids are given in acute severe if the patient needs admission to the hospital, acute severe exacerbation of COPD, or acute severe asthma or life-threatening asthma. Steroid usually it's a rule for most of the cases. Okay, so what about next? So now we give nebulizers, short-acting beta-2 stimulants, ipratropium bromide, steroids. We spoke about aminophylline, about magnesium sulfate, 2 gram IV slowly over 20 minutes. In patients with acute life-threatening asthma or severe asthma that's not responsive to the other measures. What about antibiotics? Antibiotics are not a rule in these patients. Okay, no rule to give antibiotics in patients with acute severe asthma, as long as there is no strong evidence of infection. In a patient with COPD exacerbations, still antibiotics should not be given routinely, but can be given in some patients with evidence of infection, like fever, like presence of excessive sputum, change in the color of sputum, and so on. So there is strong evidence of infection, still antibiotics can be given, but this is not a rule. Okay, so what about in patients with acute exacerbation of COPD or an acute asthma? What about ventilation? One of the common scenarios in MRCP exam, you will be asked about giving non-invasive ventilation or giving mechanical ventilation. Generally speaking, no rule for non-invasive ventilation in patients with acute, severe, or life-threatening asthma. Okay, so non-invasive ventilation is not considered in the management of these patients. Non-invasive ventilation is an important and essential part in the management of patients with acute, severe COPD exacerbation. Okay, general rule in MRCP exams, questions, you will be given the data of the ABG. Okay, especially you will focus in COPD patients. You will focus on the pH. Okay, you will look to the level of acidosis. If the pH is still in the range of 7.25 to 7.35, that means you are still playing in the range of non-invasive ventilation. Of course, so the next step in a patient, you already give all of these previous list of measures we already spoke about, and no response, and you did an ABG, and still the pH is in this range, 7.25 to 7.35. So the best next step for this patient is non-invasive ventilation, giving what we call as a BiPAP. or positive airway pressure ventilation. You may be asked about the parameters of the BiPAP. Usually, these patients are given inspiratory positive airway pressure. Usually, we give it starting at 12 to 15, and expiratory, slight PEEP, expiratory positive airway pressure. Usually, it's adjusted to 5 millimeter mercury. Okay, so centimeter water. So the inspiratory positive airway pressure will be at this range, 12 to 15, and expiratory at usually at 5. And usually a backup breathing or respiratory rate is given about 15 breaths per minute. So backup breathing, and the fraction of inspired oxygen, Phi2, can be adjusted. So you may be asked in these details, but mostly the most important question in this point is the question about the indication. Are you going to give non-invasive ventilation or no? Of course, if the patient is unconscious, completely unconscious, comatose, no way, you can't give non-invasive ventilation. This repeated, frequent vomiting, this is one of the contraindications to give non-invasive ventilation. Okay, so you must take care. You must also look to these some relative contraindications. In the question, after in a patient with acute exacerbation of COPD, you will be given the data of ABG after initial medications and steroids, nebulizers, and aminophylline even, and still the pH is 7.2, so that's significantly acidotic. And you will be asked about the best next system. Is it non-invasive ventilation or mechanical ventilation? Actually, this is a kind of tough question, and many factors need to be taken into consideration. So if in the question you have been given that the patient has a previous admission with difficult with intubation and mechanical ventilation and difficult extubation, if this has been mentioned, that means the writer of the question wants you to know that this patient has a difficult extubation, and he wants you to select non-invasive ventilation even at this level of acidosis. Okay, so if the patient has a previous history of difficult extubations, it's better to keep the patient on non-invasive ventilation. But classically speaking, if there is no any suggestive history of difficult extubations and much significant comorbidities, so your selection will be mechanical ventilation if the pH is below 7.25. Okay, so mechanical ventilation must be taken, and you must take many factors in consideration. But classically speaking, if you have been given the data of acute exacerbation and no good response to all initial measures, and still the pH is below 7.25, the best next step will be mechanical ventilation, invasive ventilation. Still in the range of 7.25 to 7.35, so that is the range of non-invasive ventilation, or giving the BiPAP. Don't forget that the CPAP, giving the CPAP ventilation or continuous positive airway pressure ventilation, it's not given in these patients with COPD. It's given in other patients like cardiogenic pulmonary type 1 respiratory failure patients, and not given to these patients with COPD. CPAP, you will want to improve oxygenation. In the BiPAP, you give adjusted the inspiratory pressure, the expiratory pressure. You want to improve oxygenation and wash CO2. Okay. So this regarding the steroid injections, then you can give steroids. You can give hydrocortisone, dexamethasone, and or oral prednisolone. You can give equivalent doses to this. So 30 milligram, 30 milligram prednisolone. You can give equivalent to this IV hydrocortisone or dexamethasone. Okay, and if it's bronchial asthma, it's 40 milligram for 5 days. Instead, you can give equivalent to this. So injectable steroids. Okay. So we spoke about the inhaled or IV steroids, non-invasive ventilations. In patients with acute severe asthma, as I said, no rule for acute, no rule for non-invasive ventilation. So if the patient presented with acute severe asthma or life-threatening asthma, so that means that the patient cannot complete one sentence, start to be exhausted, cyanosed, the patient now is more respiratory effort, oxygen saturation is, when I flow oxygen is below 92, and the BO2 is below 8, and CO2 is within the normal range, or if it's high, that means it's near fatal asthma. In these patients, if the patient does not respond to all measures, including steroids, nebulizers, and so on, and magnesium sulfate, and the patient still showing any of these signs of life-threatening or near fatal asthma, so of course you will go for mechanical ventilation. If the patient from the start presented with a high CO2, high PSO2, and these features of exhaustion, cyanosis, hypotension, and arrhythmias, in these patients you must consider ICU admission and mechanical ventilation. So regarding stopping steroids, there is no need to withdraw steroids. So this is a question. No need to withdraw here. You will give just for 5 days, 1 week. Okay, 1 week in patients with COPD, or 5 days in patients with acute severe asthma. So there is no need actually for tapering the dose. Just stop, and that's it. Stop after 5 days or 1 week. Okay, so you can stop safely, abruptly. No need to withdraw gradually. Okay. Regarding we have said that mechanical ventilation after failure of the medications is the rule in patients with bronchial asthma. No rule for non-invasive ventilation in these cases. This is in contrast to patients with COPD, exacerbation. Okay. Regarding respiratory center stimulants like doxapram. Doxapram has no role actually in patients with a COPD or exacerbation. Only if the patient showing signs of CO2 retention. So the CO2 is high, still CO2, and you already get all your initial measures and so on. And the pH in the range of non-invasive ventilation, 7.25 to 7.35, and you cannot give non-invasive ventilation. It's not available, or it's not given for whatever the reason, and still you are in this range. So no signs, no need for proceeding to mechanical ventilation. It may be given as an alternative. So if non-invasive ventilation is not available and you are in the range, CO2 retention, and the pH is in this range, 7.25 to 7.35, you may give doxapram or respiratory stimulants. So this is a bit rare scenario. It's not routinely given in these patients. So non-invasive ventilation is the rule in these patients. But if you have been said that it's not available, you can select a respiratory stimulant like doxapram. Otherwise, no rule for doxycycline in these patients, in asthmatic patients or COPD patients. This is the only scenario you may give doxycycline as a respiratory center stimulant. Okay. There is also another point we need to consider. As I said, the antibiotics, usually no rule for routine antibiotic use, but still, if you want to give, you can give amoxicillin or clarithromycin as an alternative. Sometimes you may give combination if the situation is severe. If there is severe attack, so still you can give combination of clavulanic amoxicillin, like augment, and IV clarithromycin in severe cases. Of course, in resistant cases, this is not our issue now about the antibiotic use in these cases. But in resistant cases, still you can give ciprofloxacin or piperacillin plus tazobactam. You need to think when you are giving ciprofloxacin to consider the or the special attention, especially in old age. There is risk of convulsions and risk for tendinopathy. Okay, and of course, if the patient is going to receive aminophylline, you need to reduce the dose because of the fear of aminophylline toxicity during co-administration of ciprofloxacin. Okay, it's just a simple hint about the use of antibiotics in these patients. So I think we have finished most of the commonly asked scenarios in these patients, COPD and asthmatic patients. Just we go rapidly through the scenario of pneumothorax. Usually this is a classic scenario, so you will be given a classic history. So a patient came during, there is some history of trauma or even no trauma. Usually you will be given a scenario of tall patient, okay, tall young adult coming with acute chest pain and shortness of breath. You may be given about the data of the examination, like diminished air entry on one side. There may be hyperresonance during the percussion or diminished air entry, or you may be given an X-ray or the data of X-ray which showed a pneumothorax of 1 centimeter, 2 centimeters, 1.5 centimeter, 3 centimeters, and so on. So you will be given the data of the X-ray. Sometimes you will be given clinical data, and you will be asked about the most likely diagnosis. So diminished air entry and hyperresonance means a pneumothorax in a patient with acute shortness of breath, especially in a young adult. Usually this is a spontaneous, primary spontaneous pneumothorax. Okay. If a patient also maybe one of these important scenarios of pneumothorax, a patient after car accident, for example. So you have to think in a patient coming with acute shortness of breath after car accident or severe crushing trauma. You have to think in tension pneumothorax. Of course, patient classic history, patient coming with trauma, with acute dyspnea, and maybe cyanosis, hypoxia, congested neck veins, and tracheal deviation. This is a very, very classic history of acute of tension pneumothorax after a significant trauma. So you must consider the history, examination data. So any history of trauma, you should focus your attention to the pneumothorax as a diagnosis, or a tall patient for a spontaneous pneumothorax or primary pneumothorax. Okay, coming just with acute shortness of breath and dyspnea, or acute, just maybe acute chest pain, maybe no shortness of breath at all in these patients, or maybe given a patient with COPD or bronchial asthma and coming with acute dyspnea, and you will be given some data supporting this diagnosis, or just you will be given the diagnosis and the question or the writer of the question wants you to know what is the best next step for this patient. Okay. Generally speaking, a patient with secondary pneumothorax means that secondary to a known lung disease, COPD or bronchial asthma, these patients, generally speaking, as a general rule, you must do something for the patients. If something means that usually you will keep this patient or admit this patient, okay, because the reserve for these patients is low. So even mild pneumothorax can be problematic. Okay, so in the patients with primary pneumothorax, you will look to the presence of shortness of breath, or only pain, or pain and shortness of breath. So clinically, is it only pain or pain with shortness of breath, or a shortness of breath, dyspnea, and low oxygen saturation and so on. And you will look also, if you have been given the diagnosis, you will be given also the dimension of this pneumothorax. So you will be given this pneumothorax measured at the level of the hilum. This it's 1 centimeters, or 1 to 2 centimeters, or above 2 centimeters. As a general rule, in a primary pneumothorax, no previous history of any lung disease. As a general rule, no need to. Sometime, if the patient, if the pneumothorax is below 2 centimeters, in these patients, no need to admit. If just only chest pain and it is below 2 centimeters, in this case, you may give analgesia. Okay, you may give just analgesia, and just you may discharge the patients. Okay, if it's only chest pain, if you have some shortness of breath and it's below 2 centimeters, you may give high flow oxygen. If it is just a mild shortness of breath, high flow oxygen and follow. As long if it starts to be above 2 centimeters, okay, above 2 centimeters in a patient with primary pneumothorax, go for aspiration. Okay, so because these patients primary pneumothorax, usually the reserve is good, so you can wait until the pneumothorax is above 2 centimeters, and at this point you may go for aspiration. If no response, go for intercostal tube. Sometimes in a patient with a spontaneous pneumothorax, primary pneumothorax, you may go for intercostal tube even before going for aspiration if the patient is significantly distressed. If the patient, so if you have been given in the question that the patient is significantly distressed and you have been given the options of treatment, go for intercostal tube. Okay, if no significant distress, just mildly distressed and mild shortness of breath and chest pain, just go for and it is above 2 centimeters, go for aspiration, intercostal aspiration. Okay, regarding secondary pneumothorax, we don't do this. In secondary pneumothorax, we must do something. Okay, and we separate these into 3 categories. It's below 1 centimeters, it is 1 to 2 centimeters, above 2 centimeters. Below 1 centimeter and patient with secondary pneumothorax, as I said before, we must do something. We must admit this patient and give him high flow oxygen. High flow oxygen improves absorption of air in the patient with pneumothorax. Okay, so high flow admit 24 hours and give high flow oxygen and follow up. Okay, the next step, if the patient didn't respond to this, the next step will be aspiration. Okay, if it's still below 1 centimeter. If it is 1 to 2 centimeters, aspirate. Okay, aspirate. If the patient is significantly distressed, just give tube, intercostal tube, even if it's 1 to 2 centimeters. Okay, if it is above 2 centimeter, tube, intercostal tube. This is the initial treatment. These are the common scenarios. Usually the common scenario about the pneumothorax. So above 2 centimeters, we give intercostal tube in secondary. If it's primary, no history of lung disease, go for aspiration. Okay. If it is 1 to 2 centimeters in the secondary pneumothorax, we go for intercostal tube. If it's primary and there is some, we may go just for oxygen, okay, and follow up. If it's below 1 centimeter in primary pneumothorax, just nothing, and no respiratory distress at all, so no shortness of breath, just you may discharge for follow up. If it's secondary pneumothorax and it is below 1 centimeters, give high flow oxygen and admit patient for 24 hours. These are usually the common scenarios in patients with pneumothorax. I think now it's more than 1 hour. I hope that I could help you in these scenarios, and I hope that I could make it easier, simpler for you. And sorry for such long time, and hope you the best, inshallah, in your next exam, inshallah. Assalamu alaikum wa rahmatullahi.